Hi, I'm Dr Koopmans.
And I'm Sharon Hughes-Geekie. We're your hosts of Docs of Vernon. This is an interview and podcast series designed to help you navigate the healthcare system and get to know the physicians that provide your care.
Topics include what the heck is a hospitalist, treating addictions, and alternatives to going to the ER, plus so many more.
This is your link to healthcare in your community.
Today I have the privilege of interviewing Dr. Dr Koopmans. He's a CCFP graduate of the UBC Northern Medical Program. He completed his residency training in Terrace and spent many years working rural in Labrador, the Yukon, Haida Gwaii, Vancouver Island, to name a few. He's also a father of 2 and soon to be 3, and he's also the best husband in the whole world that I get the privilege of interviewing today. For fun, he enjoys waking up with our family at 5 a.m.
Right.
What do you enjoy?
I like to play hockey. We just had the Docs hockey tournament this past weekend. And that was a big highlight for the year, I think, for most of the Docs in town that played. Also enjoy just getting out on the lake with the family and the rail trail. And we enjoy going to events and things around here for the kids in the summer, out on Ski Hill too. So
yeah, we love our life in Vernon. So we have had some requests to do almost like what I would call like a Q&A, because there's been a lot of questions, especially like family practice related questions that just sort of go on in the minds of our viewers. And so I thought, let's do a pop quiz.
Oh, great. The following should not be taken as medical advice.
Yes.
For legal purposes.
Absolutely. But all jokes aside, that kind of goes for all the interviews. And you are I call him kind of like an encyclopedia. Like when I have questions about medicine, I always call him and I'm like, what do you think? Where should I look for this? What do you know? And literally you just come up with it. It's kind of your gift.
That's very flattering, thanks.
So one of the first questions I have for you from one of our viewers is, how do you know if you have vitamin B12 deficiency?
Oh, that's a great question. I think B12 is something that's pretty common. Like people think, oh, I might be deficient in B12, and actually a lot of people take B12 supplements. So I would say B12 deficiency is usually not really recognized symptomatically. And the reason is it takes a long time, I believe, for that to show up. There's, I guess the symptoms of B12 deficiency, if you were to have them, may get some neuropathy or nerve changes in the peripheral nerves, so in your hands or your feet. And that's a really late sign. There's also some cognitive things that can happen. People can have changes in their behavior or their mental state because of B12 deficiency. But again, that's really a rare thing and a late sign. It can happen. We've had it happen in the hospital a few times. People admitted with very low B12. And another sign may be a low red blood count. So fatigue may be a presenting sign for them. But these are all actually very rare. The other thing to remember is who might be at risk for low B12. Generally speaking, it's not common to have B12 deficiency unless you're strictly vegan and not taking B12 supplements, because B12 is generally found in animal products. And then people who've been on metformin for a really long time could be B12 deficient, and don't ask me to explain why, I don't remember.
I don't either.
And then people who've been on a proton pump inhibitor, so an acid suppressant for heartburn, that can cause deficiency. And then another common thing, I guess, would be inflammatory bowel disease. So there's actually some literature to suggest we shouldn't check people for B12 unless they have a certain type of anemia or large red blood cells. But I've generally found that we do it as part of our cognitive workup for elderly people who get admitted to hospital. B12 is a water-soluble vitamin, so if you were taking B12, it's pretty hard to take too much of it. I mean, you could obviously obviously, but your body excretes the extra stuff pretty easily. So.
Well, since we're on the topic of sort of nutrition, my second question to you, which was an awesome question, this is actually one of my favorite topics to speak about, and I know you love it too. Difference between type 1 diabetes, type 2 diabetes, and can you cure either of them with lifestyle?
Good question. So I think there is confusion because people end up on insulin, and then people say, well, I have insulin-dependent diabetes. And so type 1 diabetes is developed as a consequence of a pancreatic insufficiency, or the pancreas isn't making enough insulin. And for whatever reason, it's often in children or teenagers, sometimes younger adulthood, that you would develop it. Most often it's a critical illness that leads to the discovery of the disease. People come into the hospital, they're not feeling well, and they have a really high blood sugar, sometimes incidentally found, but not often. And so that's the type 1 that people would know are insulin dependent typically. And your body isn't resistant to insulin, it just isn't making insulin anymore, enough of it. And so you need to supplement that with insulin injections. And the management of that disease has changed dramatically over the years. You have these meters now that you can just stick on your skin that last for a week, and they continuously monitor your blood sugar. And you have these insulin pumps as well, and they're starting to loop those two things where you have a closed system where you actually have a pump that feeds the insulin into your body, and it's responsive to the meter on your skin, which is really amazing, making it pretty close to our natural state. And so that's type 1. There's a lot of nuance to that, so I'm just kind of giving you an overview. Type 2 diabetes is more resistance to insulin. So it's generally a consequence of diet or lifestyle. So as you alluded to, people can modify their diet, their lifestyle, and their activity levels to manage this disease. Type 2 diabetes, your body is still able to make insulin, but the cells are resistant to it, and that's generally due to one of the biggest risk factors is abdominal obesity. Abdominal fat, for whatever reason, reduces your body's uptake of the glucose into the cells, and so you see higher blood glucose. And we care about diabetes because it can damage so many different things. It damages your eyes, high blood sugar, damages the small blood vessels, so the eyes, blood vessels in your nerves and in your kidneys, and all those very important things in our body. So there's big consequences for that. And so we do use insulin, I should say, in type 2. Unfortunately, this is somewhat problematic, as you're very well aware, Danica, because you've done a lot of work with diet and lifestyle, but for patients, the insulin we give people is kind of like a growth hormone and promotes weight gain, which promotes insulin resistance, which promotes more insulin use. And so if you have type 2 diabetes, I'm not saying that we shouldn't use insulin, but the emphasis should really be on trying other things first, and trying to lose weight to decrease your insulin resistance. Because once you get onto insulin, and my patients notice this, and I've obviously noticed this, people just keep gaining weight, and it's really hard to get off. But there's some new medications as well for type 2 diabetes, which are working quite well. So we're seeing some new things with diabetes management, so that's encouraging as well.
Yeah, and I'll add that the first line treatment for type 2 diabetes is lifestyle modification. And I think we always think like, oh, what medication do I need to take? And it actually starts long before you even are on these medications. And what you were saying about some of the new medications that are coming out, they actually are recommending that you don't start a certain medication, like one of the newer medications such as Ozempic. they're saying, hey, don't just start this. You need to actually have showed us that you're doing a lifestyle program before even starting the medication, oftentimes.
Yeah, 100%. Lifestyle, physical activity, what you're eating, those are the two keys, I think, to actually not just diabetes, but really most of our illnesses, metabolic illnesses, so obesity, high blood pressure, blood sugar, cholesterol, those things. Yeah.
Okay, last question, and this one's actually near and dear to my heart because I have a family member, I will not name who of my family, but has recently lost their driver's license. And so...
Oh, you lost your driver's license? I didn't know that.
Although my night vision is not that good.
And she did just drive over a rock the other day.
We did drive over a rock.
Yeah, large rock, not a small rock.
In my experience, not just in primary care, but often it happens when we age. We lose our eyesight or we have difficulty remembering things, and therefore blah, blah, blah. We do some crazy things on the road. And eventually a family member or somebody gets worried. Can a physician take a driver's license away from somebody?
So I think it's important to make a distinction that we aren't regulating licenses, okay? So no, the physicians don't take away driver's license. Many people may have brought in a driver's medical form, and on that form is a number of different medical conditions, and there's certain things for sure that I think it's Road Safety BC in our province, but it's across Canada, these things, and probably worldwide. So if you've had a seizure, for example, you're restricted from driving unless you've been seizure-free for 6 months, then you can resume driving. So those are some things. There's other things like, for example, having had a heart attack, certain criteria, you have to refrain from driving for 4 weeks. So there's lots of different well-established reasons not to be driving, but so those driver's medical forms just outline things, and we just talked about diabetes. So if somebody has type 1 or type 2 diabetes and they get low blood sugars and they're not aware of them, that would be another reason that somebody would potentially have their license restricted. But we don't take away people's license. We would provide a medical report to Road Safety BC, and then they will make a judgment call based on those objective findings. I think it's also important to remember, and I'm really going off here, I guess, driving often is viewed as a right, and it's not a right, it's actually a privilege. And so in order to maintain your privilege to drive, you need to be able to maintain your health and maintain safety on the road. So
yeah, awesome. I actually learned a lot from that, to be honest.
Okay.
I don't think I've ever taken someone's or needed to take their driver's license away.
Yeah.
It's not that common.
You make recommendations whether or not they're medically fit to drive.
Yeah.
I can't assess how, I kind of joke about it in the office. I say, you might be medically fit to drive doesn't mean that I can say you're a good driver. Because I don't know if you're a good driver or not.
I'm medically fit, but I don't know if I'm...
Definitely she's not. Based on that rock the other day. We all have our lapses. Can't be good at everything.
True. You know, in primary care, is there anything that comes up where you think, gosh, I really wish people knew more about this, or if there was a way I could speak into this?
I think one of the things people get frustrated about is waits, like wait times for things, wait times for tests, and wait times for specialists. And I'm as frustrated as the patients are. Often we'll send referrals, and we'll get letters back from a specialist saying we're not actually seeing anybody. Our wait time's over 2 years, and we're not going to see anything elective. We're only dealing with the urgent stuff. And so, yeah, it's frustrating. We're in a challenging time in the healthcare system. I think there's a lot of individuals with needs, and there's unfortunately just a strain all across Canada, across the board for most things. And so encourage people to continue to be patient and advocate for increasing access and not taking it out on the healthcare system in general, but maybe the people who are responsible for administrating that, I guess, which is to say our government, who's managing that piece. So.
Yeah, that's a really good point. Thank you.
You're welcome.
Well, thank you very much for being here and giving your time.
Yeah, and now I gotta go head to the hospital here.
Night shift.
Yeah, so I'll see you tomorrow.
Thank you guys so much for tuning in, and we will be connected below. You know how to access all the links from here on out. Bye for now.